Good afternoon, everyone. Welcome to the South Yorkshire, Derbyshire and Nottinghamshire Joint Health Overview and Scrutiny Committee on this 25th of March 2024. The meeting today is open to the public, and a warm welcome to all of you in attendance and anybody watching online. My name is Councillor Ruth Milsom. I'm the chair of this Joint Health Overview and Scrutiny Committee and chair of the Sheffield Scrutiny Subcommittee. Before we start, there are just a few housekeeping arrangements. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is in Tudor Square, outside the town hall. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. And by entering this meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Can I please ask that members and officers in attendance introduce themselves? If we go to my left and if members and officers with them can introduce themselves first. Thank you.
I'm sorry. Jane Murphy, Scrutiny Officer for Barnsley.
Councillor Jeffrey is chair of Barnsley's Overview and Scrutiny Committee.
Caroline Martin, Senior Governance Officer at Doncaster Council.
Glen Smith, Chair of Health Scrutiny at City of Doncaster.
Good afternoon, everybody. I'm Laurie Brennan. I'm the Head of Policy and Partnerships. I'm here standing in for Deborah, Glen, who usually helps and supports this meeting. Thanks.
Joanne Cooper, Democratic Services.
Thank you very much. We've had apologies today from Councillor Yassim from Rotherham, Councillor Wheeler from Nottinghamshire and Councillor Warmby from Derbyshire. There are no items that require the exclusion of the public and press today. And finally, I wish to ask members whether they need to declare an interest in any of the items of business on the agenda. None? Thank you. Right, so we go on to item 6, minutes of the previous meeting. Have members read the minutes through? Rather than go through page by page, if I can just ask if there are any issues with the minutes or any matters arising that we haven't noted. Happy? Councillor Ennis?
Yeah, happy with the minutes, Madam.
Thank you, that's great. Okay, so that was item 5, sorry. Item 6, public questions. We haven't received any public questions today. That's it. And then on to item 7, which deals with the change to terms of reference for scrutiny committees following change to national policy at the end of January this year. We've got a verbal update from Laurie today as our Head of Policy and Partnerships. Thanks, Laurie.
Good afternoon, everybody. Thank you for hearing this item this afternoon. You've all got in your packs a version of a publication from the Centre for Governance and Scrutiny, which summarises some changes that have been talked about since the introduction of the Health and Care Act 2022, I think it was. And what this does, it updates the regulations around health scrutiny at local level. If you turn to page 12 of your packs, there's that page really summarises some of the absolutely critical changes, what we're expecting as part of this. It actually came into force on the 31st of January this year already. So essentially, new rules have been put in place to ensure that with how health scrutiny operates, previously under the previous model, health scrutiny at local level, so in your individual councils, but also through joint arrangements like this one, could effectively refer items to the Secretary of State around significant reconfigurations of local health services. What the change to the regulations means is that the local health committees like this one will no longer be able to do that. They won't be able to formally refer issues to the Secretary of State where there is a significant change to local health services. Instead, what happens is the Secretary of State themselves will have a broader power to intervene in those sorts of changes. Health committees like this one and local scrutiny committees will still have the right to be formally consulted, and it's expected, incumbent on the local ICB, for example, in our case, to refer these things to local scrutiny, but also to the Secretary of State. So there's a clear perspective on those reconfigurations that are happening at local level. But I would argue that here as well, there's a significant shift in emphasis to us developing quite strong collaborative relationships with local ICB partners to ensure that we have a connection around the forward plan for any significant reconfigurations, and we can use our mutual kind of connection to local communities effectively in that space. As the NHS as an NHS commission, I can't say it. As the NHS commissioning body must give effect to any decision the Secretary of State then calls in. So if the Secretary of State undertakes a calling exercise, they must follow the reading of that Secretary of State in that particular instance as well. So essentially, in a nutshell, that's the change. One of the things we may want to consider as a committee here is how do you want to undertake some of that relationship with our ICB, and how do you want to initially approach that conversation. In this document, there's a suggestion that members may want to look at developing an MOU as a sort of arrangement for understanding, something you may want to consider as part of your work going forward, but maybe some collaborative activity, certainly with the ICB, to think about how we best approach any significant reconfigurations to ensure that citizens are getting the best outcomes from the services in the local area. Thank you, Chair.
Thank you, Laurie. Do we have any questions or comments about this item? I think I'd like to comment that I do find it very disappointing that scrutiny committees have been stripped of that power to refer anything directly to the Secretary of State. It seems like a weakening, really, of scrutiny powers, but given that, I think it's really important that strong relationships are forged and maintained between local authorities, and in this case, the combined South Yorkshire authorities and the integrated care system as a whole, and colleagues from the Integrated Care Board. So having said that, I hope we can maybe look at developing a memorandum of understanding before too long, once the election period is over, maybe move straight into collaborating to do that together. The colleagues happy to move on that quickly after May and establish some terms of reference for working together. A lot of that, I believe, needs to be not just on paper, but we do need those relationships, and really thankful to ICB colleagues who have been willing to give a bit of extra time to forging those relationships with elected members. I do think that's important. I wonder as well whether we might want to schedule in regular briefings with the ICB, informal briefings, just to look at anything, a bit of horizon scanning, so that we can hopefully develop a nice culture of no surprises, and really work together in the best interests of everybody in South Yorkshire. So I think have we got recommendations on this report? No. I think we're just noting the report that Laurie's given then, in which case, and agreeing that we'll move forward with the necessary steps to forge stronger relationships in the new council year. Agreed? Thank you. Okay, thanks Laurie for your input, and I realise you need to go when you need to go, so just slip off when you need to. Thank you. Right, we are now on to item 8, which is entitled Start with People Strategy Refresh Update, ICB Citizen Involvement Strategy. Just trip that off the tongue. And we've got Katy Davison, Deputy Director of Involvement from the ICB, to present to us. So you've got a presentation for us, Katy, and thanks for sending your report in advance. So take it away when you're ready.
That one. There we go. Sorry. Okay. Can I have the second slide, please? Do I do that? No. Essentially, the slides are more or less just a tool for me to use to talk you through the key points of the paper. There are a couple of updates in there that have happened since the paper was written as well, so I'll just drop to those in. So we have a Start With People South Yorkshire strategy for the ICB. It was launched on the 1st of July when the ICB came into being because we were nationally required to have one. And obviously we wanted to have one, but that was the deadline we had to have one for. When we wrote the strategy, we did do some work with our communities and stakeholders. I think we probably did come here at the time or sent it to you electronically. And we did that as widely as possible at the time, but we did accept there were quite a lot of limitations. When we put that together, we were still 4 organisations very much in our makeup. The ICP wasn't in place, and there were lots of very tight deadlines placed on us at that time. So we knew that as the organisation grew and changed, we would want to refresh our strategy. So we deliberately put a 1-year timescale on the strategy. We've also had feedback since when we did that, since we published it, that our partners didn't feel that they had much ownership of it, much buy-in. I think that was probably due to the limitations of when we put it together. So we've now come to refresh it. We were slightly delayed in our refresh, again, due to a number of things that were happening with the organisation. Some of the things I brought here, like the ICP strategy involvement work and the joint forward plan involvement, taking up a lot of my team's capacity, but we've now started the refresh of the strategy, and we're taking a much more stakeholder driven approach that we hopefully get ownership from across the system. What I just want to say, and the reason I've included this strategy is because I didn't want you to think that because it's a year and a half since we wrote the strategy, we haven't done anything in the meantime. We've got a really good, strong bunch of engagement professionals in our team. As I said, you've seen a couple of the things that we've been doing. And we also spent some time looking at the principles in the strategy, identifying what outcomes we could achieve from those principles, what outputs would mean we'd achieve those, and then some actions. And we've been working through those actions as a team. Quite a lot of those are internally focused around making sure we develop an organisation that thrives on involvement and embeds it at its heart. What we then did when we looked at our actions, we thought, actually, do you know what, they could be summarised into these 3 priorities. So these are our 3 priorities for involvement, and they go through all of our organisational documents like the joint forward plan and things now as well. Next slide, please. So in October, we started to socialise a bit of a high-level involvement plan. We did send it to yourselves. We did get a response from Barnsley with some comments that we tried to take on board. And then in November, we started looking at what we'd already heard from citizens in various involvement pieces of work across the system. So that included looking at the initial involvement activity we'd done in 2022, but it also included working with all of our partners across the system about what they knew our citizens had already said to them, because we do hear time and time again people saying, please don't ask us the same questions that you've asked us before. So we did a bit of a report on what we already knew about how our citizens wanted us to interact with them. Then we held a task and finish group that had sort of people from the system who work in involvement roles like myself. So that included representatives from the local authorities, from the voluntary sector, from Health Watch, various other parts of the NHS, and some citizen representatives as well. And then we used the themes from that workshop to shape a 6-page citizen involvement plan, which again you'll have had in the papers, which looks like this. Next slide, please. So this is just a snapshot from that citizen involvement plan, and gives you a chance to see the range of ways that we asked people to be involved in our work. We promoted it as widely as possible. Again, you can see that in your papers. I've included quite a detailed list of the places we've sent it, including to your support teams, because I know when I've been here before, you've said to us, please use us and other elected members for sharing this with constituents. So we did that. We also worked with our health watchers to communicate and work through the voluntary sector with some of our most underserved communities and the groups of people that we struggle to hear from the most by just doing things like drop-ins and surveys and things. Next slide, please. So this is one of the things you haven't seen in your paper. This is as we're starting to get the feedback now. So this is a snapshot of some of the comments that we're starting to get from some of our citizens. I think you'll see that generally they feel like we're on the right track, but there are improvements that could be made. There's some key themes coming out now around things like accessibility, wanting to see that the involvement that they are having with us is making changes, and various other themes. Next slide, please. Okay, this one's really small, so I have deliberately written the list out in front of myself. So this is a bit of a summary of the key themes, looking at all the documents and all of the involvement that we've done. And so what Helen from my team has done is pulled out what she's found to be the sort of there's 18, I think, key themes, and then she's listed where in the various different involvement activities we've heard them, so that you can see that we are hearing these themes repeated. The things that we heard were build trusted relationships through partnerships and networks, widen diversity and hear from more people, ongoing dialogue, not one-off asks, really listen, go to people and communities, have openness, honesty and clarity, have shared values and priorities, have better communications and information, be simple, brief, use images, use a variety of methods to meet access needs, make sure you have events that are interesting, interactive and informal, use images in plain English, no acronyms, resource the work properly, have decision makers in the room and show the clear pathways to decisions, involve people early and throughout, co-production where possible, feedback to people, show impact, visible reports, resource the VCSE and not short term and both large and small parts of the VCSE, value lived experience, build community experts and connectors, use what we have, both information and resources, and involve me in what matters to me. So we're working through all of this now, ensuring it's reflected in the strategy refresh, but also in the evolution of our involvement approach. So we're looking at things like investment into the voluntary sector to help us hear the citizen voice in a more ongoing way, more opportunities for community organisations and citizens to be able to invite us to their meetings, contact us more easily, to help us build better relationships with them, better access for citizens who'd like to have conversations with our non-executives, much better mechanisms for letting people know how we've acted on what they've told us. So just really lots of fairly straightforward things that we think we can bring in fairly quickly to help people, to help us to demonstrate to people that we've heard what they've told us. Next slide, please. As it says in your papers, we've also undertaken a broad range of stakeholder meetings to ensure we've given as many stakeholders as possible the opportunity to input. Next slide, please. We've also, as I've just referenced, started a co-design approach with the voluntary sector to help us develop together a mechanism for us to work together to hear citizen voice, particularly from our underserved communities. So far that's involved a workshop attended by 40 to 50 people and a follow-up webinar. And I think we're really keen that that's ongoing work, and it will stem past the strategy refresh, but we will make sure we've got the commitment within the strategy, but we really want to work with our voluntary sector to develop together what that looks like. Next slide, please. So in terms of next steps, as you'll see the involvement report, I showed you the key findings that are just emerging. We're finalising that. We're rewriting the strategy on the back of that. The citizen involvement work with the underserved communities via Healthwatch is continuing because they felt very strongly they needed a longer period. But what we're doing is we're in the period now where we rewrite the strategy. Then we've got a 2-week period for our readers panel to look at it for us and give us some their views. And I would really welcome if the JOSC would be interested in seeing that, to share that with you at that point as well. And then we'll get all that in, we'll get the Healthwatch feedback, that'll close then as well, and we'll get that in, and we'll spend, I think it's a couple of weeks again, just finalising the report. We're going to put some proposals to the organisation around additional involvement mechanisms, some of the ones I've mentioned, and some funding. We're ongoing, the VCSE work is ongoing, and we've also, through the start of this work and our task and finish groups and working with other involvement colleagues from across the system, we're looking at what system-wide commitments we could put in place for citizen involvement as well. And then the final slide is just so you can see some of the concepts of what we're starting, the emerging strategy is starting to look like. So we're taking on board things like making sure it's engaging, it's colourful, it's easy for people to understand, the colour tabs down the side, and I have had some feedback today that we need to make this clearer. Each colour will relate to a section of the strategy, and the strategy is designed so that they're almost like information sheets, so you can go directly to the section that you're interested in. So if you're only interested in the governance, you can go there. If you're only interested in what the opportunities are for us to involve you, you can go there. If you're a young person, you want to know how you can get more involved and what work we've got in place to more actively involve young people, you can go straight to that section. So, and that's it. I'm happy to take questions.
Thanks very much, Katy. Right, any questions from members? Jeff?
Yeah, thanks, Chair. I mean, given the shortened timetable that the office has had in developing the people strategy because of the later implementation of the ICB, etc., I think they've done really well to try and make as much contact with the voluntary sector, councils, Health Watch and organisations like that to get their feedback. And I know it's been quite an expensive exercise as well. And given the small number of actual individual replies that we've had, I think it's just 400 and odd or whatever, I can't remember off the top of my head. Do we think we've gained value for money? And I know we've still got to evaluate the feedback from the original document and then provide the grand master plan of the people strategy in the next few weeks or so. It's just really to get feedback in terms of, do you think we've achieved value for money, and we're going to achieve further value for money when, at the conclusion of this exercise?
Thank you. I'd like to think that, I mean, I can tell you in honesty, because I've been to all the focus groups and the drop-ins and things, that we have definitely learned things from our citizens that we will implement on the back of this. So I think there's definite value in this. Do I think that one-off involvement exercises on things like strategies are the best way for us to involve our citizens and therefore give us value for money? Probably not, because we really struggle to engage citizens in what people can see as a really dry subject. They can't immediately see how it affects them, like you could in a way, like if you were telling people that their GP practice was closing, or or you were moving services type thing. What we really want to do with our involvement work is switch to a much more ongoing dialogue approach, whereby we're hearing from people all the time about what matters to them, so that when we come to write things like the Joint Forward Plan and the ICP strategy, we've got that insight bank of, we know what's really important to people in South Yorkshire, and we can start with that rather than trying to re-engage people in conversations that they feel that they've already had, and that it's really hard to do. And I think that will be a much better value for money approach to involvement going forwards.
Can I just come back on that, Ruth? Because, yeah, that's a really good response. I originally come from Grimethorpe, which is still categorised as the most disadvantaged community in the whole of England because of the pit closure programme and stuff like that. And it's very important, I know personally from being chair of Overview and Scrutiny, how important it is to try and engage with the members of the community that's disadvantaged. And whenever we've done in-depth topics on our Overview and Scrutiny, we get most of our best recommendations from the people who are on the ground floor, as it were, in terms of facing deprivation. And I think that's got to be an important point, Katy. Keeping engaged with the disadvantaged communities, because they will lead you on the straight and narrow path as far as I'm concerned.
Thank you for that, Katy. I'm interested if any elected members were part of the stakeholder group, and I suppose what was the response, because I'll hold my hand up here. I wasn't at that meeting on the 28th, but, you know, I may well have been involved had I been there. And I suppose the other thing that I'm kind of really interested in are around the learning disability surveys and how they were done, what easy read information was used, and were experts by experience taken, you know, onto the team to give you some support.
Yeah, I'll take that one first, if that's all right. So we work with an organisation called Speak Up. I don't know if you're aware of Speak Up. So Speak Up basically took this off my hands and said, let us do this. So they took the survey questions that we'd written. They actually gave us feedback on how they thought we could make them more accessible to the public, as well as making their own easy read versions. And they did a lot of group work with their citizens. I believe most of the people who work for Speak Up themselves have learning disabilities, but they were definitely experts by experience involved in all of those elements, and they will be on an ongoing basis as well. That's why we've given a separate section of the involvement report to working with the learning disability autism community, because the way that we involve them has to be so totally different to the way that we involve, you know, sort of the wider public. So and then the other question was, elected members, sorry, yes. We sent out the original high-level report to the elected members, to the scrutiny members, and we got the response from Barnsley, and then we sent out the involvement report and asked the membership teams and the support officers to make sure that the JOSC members and all elected members had had it. I didn't get any feedback or any attendance at any of the meetings on the back of that, in all honesty. I think it's probably still an area where we could better develop our relationships. I am very dependent on the membership sending things out for me, and in all of the exercises that we've done now that I've led on, it hasn't ever led to a great response from members, if I'm totally honest. So I wonder if there are better ways that we could do that, but I'm definitely open to exploring that, because I recognise that we have a massive untapped resource there.
Yes, I would say that. I actually chair the Doncaster Learning Disability Partnership Board, and, you know, wasn't aware. And I do know Speak Up very well. I have worked with them and done training with them. But, you know, there are equivalent groups, I'm sure, because they're specifically a Rotherham group. And there are equivalent groups, I'm sure, in other parts of South Yorkshire that might be able to give you some different information. Thank you.
Thanks. I've got a little raft of questions here. I'm going to plough on, but I'll keep an eye out for hands. Don't let me just hog it. Katy, I think I was really glad to hear you mention about where you've invested in voluntary organisations to help with engagement. I think there's a really clear success there you've accounted for it in last year's involvement report, with the future of learning disability and autism services in Sheffield, where you used MenCap and Gateway and Sheffield Mind and paid them to do it. It's such an obvious way to get results, isn't it? So I'm really glad to hear that the commitment to that is still there. But it kind of ties in with a question that I've got about to what extent is your involvement work likely to be affected by the 30% cut to the ICB's operational budget. Will you be able to do that kind of engagement work, paying external organisations in the same way?
Thank you. I mean, I'm not the finance director, but yeah, I hope so. There is a massive commitment that I see in the ICB to involvement, and there's also a recognition that to do that involvement well, particularly with underserved, disadvantaged communities, working with the voluntary sector is absolutely the way to go, because they have the trusted relationships, they understand their communities, they've got all the cultural competencies to have good, strong relationships and good conversations with them. So my pitch around funding to my colleagues will be, we end up doing this anyway for each individual exercise, and that's not best value for money. So let's take stock and resource this in a much more cost-effective way.
Yeah, thanks. Yes, Anthony, you've got a point.
Might be fair for me to help Katy out there as a board member of the ICB. I think there is an absolute commitment to the board to maintain but improve the way that we engage with our residents, and some of that is about working better rather than harder with more resources. So we're very much committed to working with other partners as well as the ICB, such as the voluntary sector, but some of our providers, etc., in the way that we engage. I think it's fair to say that across our towns and cities sometimes we've been a bit disparate in the ways that we do that. But what I've seen from the engagement strategy from the ICB is that there's a commitment to do things once and well where it makes sense to do so.
And are you building a directory for yourselves of organisations that are on the ground and can be really useful in this?
Yeah, we're taking sort of a multi-pronged approach. So there's obviously we have a programme director for VCSE work within the ICB, and there's an alliance, VCSE alliance, and she works with them. So we sort of take that as one approach, and then we do our own outreach work with the voluntary sector and community organisations. And like I said, we're looking to invest in that a bit more strongly, because when we went to drop-ins and things, what we've done historically is use the alliance and use the umbrella organisations to reach community organisations, and a bit like what I probably reflected with the members, it's not always that reliable to rely on other people to pass the messages on for you. And what we found when we went to our drop-ins and things, we were getting people from the small community organisations coming and really wanting a relationship with us, so we really want to harness that. So yeah, absolutely, we will be building up our own relationships and our own networks of organisations.
I think as well, without meaning to sound challenging, the word commitment always makes me nervous. It's right, so absolutely hear you, you're committed to doing this, but there has been a cut to the budget, and commitment is a word you hear a lot from, shall we say, people who don't always follow through in government. A commitment is a great word because it sounds like it's going to happen, but I think we're probably really interested in seeing how it's going to happen, you know.
I think that's more than fair. The proof's in the pudding, isn't it? And that's absolutely implemented. I've got good confidence in the plans that are there, but equally happy to be held to account and scrutiny about whether they're actually working, both from committees such as this, but from our public as well.
I'm referring back to when the consultation, the engagement exercise was run in December 22, the What Matters to You consultation, and I'm not a social scientist. I don't know the answer to this, but it was it's in the last year's involvement report. It does say that exercise had about 500 respondees. And that actually what you consider you need to get a high confidence rate, is it 90, you go for 94% confidence rate, I think, or 96, is what you need is about 400 responses from a population of 1.4 million people. But I find that a bit extraordinary. That's not, so the number of people who responded to that consultation was 0.036, not even 0.1% of the population, but a third of that. And you know, from 1.4 million people, I know it was a really rushed exercise and there was nothing you could do about that, it was out of your hands. But for next time, when that exercise needs to be repeated for the next ICP strategy, what learning has there been from that to carry forward? And are you going to stick with that sort of 500 responses is enough, or are you going to aim a lot higher?
I I think this goes back to the ongoing dialogue and communication with our citizens, and then feeding that into the Insights Bank. And actually, what will we already know from our citizens? Who will we have already heard of? And what we're hoping to do with the Insights Bank that we're building is to be able to dip in there then and say, do you know what, we've heard from hopefully many more than 500 people, and actually what are the things we think we have heard about and what haven't we, and who are the people we have heard from and who haven't we, and then we can do a much more targeted approach to make sure we hear the voices that we haven't already heard from, and we talk to them about the things that they haven't already told us. And we think that we'll get better engagement that way, because, as I said, it's really difficult to engage with people about something that they can't see immediately affecting their daily lives. So I'm hopeful that that will be an improved approach.
Yeah, sorry. I think there's definite learning. I think that's the point really well made. The numbers on their own, if taken in isolation, are quite limited. Let's be fair on that. However, I think the approach that Katie's describing is one that there are other avenues and much engagement and consultation that we've done with our public that we need to draw in already with these plans. So I think better use of what we've got, which stops the frustration of some of our residents that you're coming out to ask us again. I only told you this last year. Come back and tell us when you've done something about it. So there's an element of that approach, but also using different methodologies and learning from the exercise that we've had, working with our health watches better for this exercise. So the point I think you were making, Ruth, is well made, that actually there's learning out of the last exercise taken to the next one.
Yeah, thanks. I mean, I will underline, it was, you had your hands up your back, really, with the timescale. It was horrible to try and achieve anything in that timescale, but I think my point is in the report, it says that the report from last year suggests that was adequate and that was a good response, and it's 500 people. I know I've got, more than 500 Facebook friends. Anyway, Katy, you commented about the sense of ownership and buy-in from partners, and that was very low when you first launched the strategy, which is understandable under the circumstances that you described. But what kind of things have partners asked for and suggested as improvements to that would help them feel more buy-in, and have they been acted on, and is that starting to come through? And to what extent is involvement like a two-way street? So is it always the ICB that will initiate an involvement exercise, or could it be a partner that initiates it? And I'm just flagging up that this morning, although we've postponed the event, this morning here in this town hall we would have had a public engagement event on dentistry. We're fairly relaxed about the timing of it because we want people to be involved. So we didn't get that many sign-ups, and we've listened to what people said about that, and we're going to reschedule it for a time that's more convenient to people. But that is initiated by the Scrutiny Committee, which it's not the same thing as a partner, in health actually initiating it. But is there scope for that? So, can an engagement exercise be requested, or might it be stimulated by things you're hearing externally?
Yeah, absolutely. As you said, involvement's a two-way street, and actually really good involvement is bottom up, isn't it? It's not us telling people what we want to have conversations with them about. I think one of the really nice things that's come of the approach we've taken to refreshing the Start With People strategy is a bit of a community of practice of people who work in the sort of involvement world. And I say that loosely because there are people who work in involvement and have involvement in the title, like myself and others in other parts of the NHS, but it's not always that obvious. The local authorities have numerous posts of people who do involvement. Voluntary sector organisations, by their nature, pretty much everybody that works for them, in some of the smaller ones, are involvement professionals. So we've been very loose about who we've invited into our community of practice. And I think the feedback that we get is that they just feel empowered and happy to be having the conversations with us and developing the work. I mean, we did have a conversation about whether the refresh of the strategy should make it a system-wide strategy. I think we felt that there were too many different organisations in different places with their involvement approaches to do that, but there's definitely a commitment to having some kind of documentation or framework or something that all of the partners in the system sign up to, because I think we're all committed to the fact that we want to involve our public in a meaningful way. We don't want to be repeating things. We don't want the ICB to be asking them something one week that the council is asking them the next week, and we need to have a much stronger community network of people who do involvement to stop that kind of thing happening. So that's certainly been one of the positives to come out of that, and we haven't really started to shape what that might look like yet, because colleagues have been fantastic, to be honest with you, at wanting to be engaged and help us to write a much better strategy for the ICB, but that'll definitely be the next thing that we move on to, is how can we do this this sort of system-wide commitment or framework or whatever it is. The other thing that's been happening really nicely is those sort of conversations happening at place as well, and it's at different levels in the different places, but there are involvement networks happening in place. Barnes is a really good example of where they've for a while now been working together, and different parts of the system lead on different involvement, and they all work together to make sure that works for the citizens of Barnsley. So I think we're really looking at how we can replicate those approaches in other parts of South Yorkshire as well.
That sounds good. Just lastly then, what happens beyond the completion of the plan and the implementation of the refresh strategy? So how will performance be monitored? What kind of metrics have you set to monitor performance? And is there also a forward calendar of involvement emerging from that? Just for our benefit as well, thinking about what the role for the Joint Scrutiny Committee is in future involvement exercises.
Yeah, 100% there will be a future involvement plan, and that's what we'll share with yourselves and sort of our partners like Healthwatch and things to help us plan ahead for what conversations we need to have and what involvement activity is coming down the line. I've forgotten what the beginning part of the question was.
Performance monitoring.
Oh yes, really timely, because we had our task and finish group this morning with involvement professionals, and we looked specifically at measurement, and I wish I had an answer coming out of that meeting for what our measurement tools might look like, but we, as we do in our world, tend to give ourselves more questions than we answer, I think, but lots of really good discussions about how what good measurement for involvement looks like. We talked about numbers. Is it involving this many voluntary sector communities? Is it this involving this many citizens? But actually I think somebody said, well, you could involve 10,000 people and do nothing with it, or you could involve 500 people and actually make some meaningful change on the back of it. So we're really looking at how we measure our involvement based on what outcomes that we might achieve for our citizens as well. So we're working that through, and I think it might be another area of the strategy where we aren't quite nailed yet when we write the refresh of the strategy, but we will be committed to developing the work and having a measurement framework that sits behind it, possibly at a slightly later date, I think.
Just lastly, what advice would you give to elected members who handle casework and inquiries from their constituents and might not necessarily think that it's something to feed up? So, you know, you said about involvement being bottom up, and it sounds like you're gearing up to take a lot more kind of ad hoc involvement and listen to that and bank it, which I think is a brilliant idea. So, you know, say I've had a constituent contact me about difficulty accessing care in some way. What advice would you give me on how to make sure that gets heard?
I mean, I think if it's experience, it's really difficult in the NHS because we're so fragmented, but I guess probably the first port of call is the organisation from who they've had the bad experience with, and then our systems should feed that up to us as well. But we are recognising that it's quite a fragmented system and it's not always easy for the public to understand. We are trying to make it easier to come to us as well, so we're going to make ourselves much more accessible, and so I think, you know, pulling the information through to myself and my team would mean that we could help make sure it got to the right people. We're also developing our insights bank, and again, elected members might want to upload to that. So it's going to be open source, and again, it have to be confidential and anonymised. But if there are key issues that you're hearing about repeatedly, if you wanted to input them into the insight bank, that would help us to again pull out the themes and trends of things that people are telling us really matters to them.
I think it's fair to say that sometimes this process can be a bit confusing, both for residents and for elected officials to try and represent residents. I think things have changed in the last year, nearly 2 years. We've tried to take the approach that I think worked in each of our towns and cities and put it together into a South Yorkshire approach. So we'll get better at communicating the methods for that, because I think there's some work to be done. Short of that, though, Chair, any member of the directors or executive board will receive any letter that you write to us or any resident writes to us and respond accordingly while we work on the processes to make it simpler.
Thank you. Is Health Watch a good route as well? So I might advise my resident to contact Health Watch with their, if it's a complaint or if it's a concern about something, and Health Watch presumably report back to you on a regular basis. Any other questions, members? Or any other comments? Okay, brilliant. Thank you ever so much for coming and presenting and answering all our questions. We are asked as a committee to note and consider the stakeholder and citizen involvement approach to the refresh and the proposed structure and development of the refreshed strategy. Are we happy, members, to note those things? And are there any further comments? In which case, thank you very much for attending, Katy, and see you again soon, I hope. Going to stay, thanks. Good luck as you go forward with the strategy. So item 9 on our agenda is Dentistry in South Yorkshire. Now, back in August, this committee asked for a sight of a plan for dentistry in South Yorkshire, with the ICB having taken on commissioning. When was it? July last year. So obviously in August it was very early days indeed, but we looked at the joint forward plan, and I think we raised some concern that dentistry didn't seem to have much focus in that plan. So you've brought us a report which lays out a bit more of what the intentions are locally. So Anthony, is it you?
Yeah, I'll kick us off, Chair, if that's okay, and then I'm going to hand over to the experts and I'll ask them to introduce themselves first.
Okay. I'm Debbie Stovin. I'm the dental programme lead for South Yorkshire.
Hello, I'm Sarah Robertson. I'm a consultant in dental public health. I actually work for NHS England, but I support South Yorkshire ICB around dental commissioning and oral health improvement that the local authorities commission.
Thank you. My name's Anthony. I'm one of our executive directors on the ICB board, and my portfolio includes dental, or at least it has since July, as you say, Chair. So I think we've been on the forward. Thanks for inviting us. I think we've been on the forward agenda, as the Chair says, for a while. We held off for a number of reasons. First of all, as referred to, that the dental responsibilities that we've taken on from NHS England become embedded across the ICB. A lot of those first few months were, quite frankly, technical, learning from the experts, but ensuring contracts were in place, financial, etc. So that was a lot of our early work. We also held, and this will be referred to, and I think some members were at that event, we held a dental stakeholder event in November, which was an opportunity to jointly plan for our plans for next year with professionals, patient representatives and elected officials. And finally, we were awaiting a National Dental Recovery Plan, which was published earlier in this year, and what Debbie will be referring to in the report. So members have had a paper with the pack, and that's going to be supplemented by some slideshows in a moment. And that paper tries to do a number of things. The first, I guess it gives a state of the nation, really, in terms of where we are in South Yorkshire, both in terms of access, but also in terms of public health and our position for both children and adults in South Yorkshire. It describes the headlines of the National Recovery Plan and describes the main focus of our plans for next year. The ICB board received and approved our approach to dentistry and oral health in March, and I would describe that approval as cautiously optimistic about our ability to address some of the issues facing our residents across South Yorkshire at the moment. We do think we can start to address and chip away at the issues of access to NHS dentistry, and we'll go into those in a little while. And we do think that some of our schemes, such as our homeless schemes in Doncaster and Sheffield, which we're looking to roll out into other areas, can address some of the needs of our most vulnerable people. We have got some innovative ways, as much as we can work innovatively within the NHS dental contract, to work differently in our approach to dentistry. And again, Debbie will describe some of those. And I do think we have good support from our professionals across dentistry and oral health in our approach. However, Chair, we do need to be realistic. Dentistry access, as I'm sure members know, is hindered both by national contract issues and a long-standing workforce recruitment and retention problem. There are things that we can do with that, but it won't be an overnight issue. And there are longer-term generational approaches that we feel would have a bigger impact upon both our children and young people's oral health and longer-term adult oral health in South Yorkshire. And I'm going to ask Dr. Robertson later to discuss some of those further. At the end of Debbie's presentation and after questions, there is some support that we would welcome from yourselves and this committee. We have tried to get out there more, to be more open and transparent about dentistry and oral health in our towns and cities. Equally, we would value your help in promotion of campaigns and involvement in public consultation, and that's timely, as there has been a particular one launched today, which again Sarah will describe. I hope that serves as an introduction, Chair. I'm going to hand over to Debbie to go through the slides.
Hi, so Debbie Stophen. Okay. So I'm just going to I've got a couple of slides regarding the recovery plan, which Anthony referred to. So this is the National Dental Recovery Plan. It came out early in February. There wasn't much notice literally for us to get to this. So I'm just going to do a quick snippet of the sort of key points from that. So the plan, faster, simpler and fairer, plan to recover and reform NHS dentistry. It's very much focusing regarding supporting access to NHS dentistry and improved preventative care. There's three broad elements as detailed there on the slides regarding preventing poor oral health, boost access and activity, and building capacity for the long term. And what I'll come on to in the next few slides is how that impacts on South Yorkshire. Next slide, please. So the first bit regarding preventive poor oral health, I have bracketed that public health and local authority-led initiatives. So that is where that fundamentally that these will be delivered from and worked on, rather than within, within sort of the ICB's responsibility regarding commissioning dental services. The bit in there as well, which will be the interesting bit, I think, particularly with the launch today, is the government's plan to take forward consultation on expanding water fluoridation and the consultation that's taking place in the North East. And we can maybe come on to that shortly, and I'm sure Sarah can provide some more information on that for you. The second part, addressing an urgent need to boost access and activity. So what I've included there is sort of the key bits that are actually in the recovery plan. The first being increasing the minimum units dental activity, so the UDA value. So our primary care contractors, your high street dentists, are paid on a UDA basis. And we did have 7 practices that fell short of the £28 as the minimum UDA value, and that they are actually all being uplifted from the 1st of April. They are all retaining their current levels of activity, so we've actually agreed across South Yorkshire ICB to uplift their total contract values. The alternative would be they retain their value and reduce activity. And thankfully, all 7 of them agreed to retain their activity level, so that's not being jeopardised. The new patient premium, I think, is the bit that seems to have got, initially when it was launched, the most noise as the way of actually increasing access for NHS patients. And that started on the 1st of March and goes through to the end of March next year. So it's only a 12-month plus one programme by the national plan. So this means that the dentists can actually receive an additional payment on top of their current payments for band 1 for the £15 per patient. That's usually sort of your routine checkups. Band 2 and band 3, they're the more bits where you will receive treatment. So you're looking at your extractions, your fillings, your root canals and things like that. So for seeing a patient for that, they can get an extra £50 per patient for that treatment. Which sounds positive. However, we need to look at reality, I think, again on that, and actually whether that is enough of an incentive for a dental performer to actually take on 2 new NHS patients. All the practices in South Yorkshire have decided to opt in. None of them have opted out as yet. It is a voluntary thing. They don't have to opt in to do this. So our returns back to the centre have been that they've all opted in, which is positive. Ultimately, it means that practices can actually achieve their contracts targets sooner. This isn't additional money on top of existing contracts. This money will actually be paid for within their current contract values. So there is a potential risk on practices being able to achieve their contractual targets for the year a bit earlier, or actually more likely to meet their contract targets by having the additional payment paid within their current values. It's worth pointing out potential risk with this, where practices may choose to focus on new patients as opposed to seeing their current regular patients on those sort of routine checkups. It may delay. We don't know what's going to happen yet. We haven't seen any metrics for this yet. It's very new. We're literally 25 days into it. So it is something that we'll be watching out. The other bit in there is regarding a dental van service. South Yorkshire ICB are not actually identified for this initiative. It's been focused on those more rural areas. So our colleagues in Humber, North Yorkshire, they are on the list for that initiative. Golden Hello payments to attract dentists to areas of need. So this is where there's an incentive over a 3-year period for somebody to receive an additional £20,000 over 3 years to be able to work in a particular area. We've not yet received the locations of that. We don't know where they're going to be targeted, so we don't know if any of those areas will be in South Yorkshire. Next slide, please. So the third part, supporting and developing the whole dental workforce and building capacity for long-term support. Some of this is part of the NHS long-term plan and it's building in that, and some of this is obviously going to be tied into national programmes of work regarding expanding training courses and expanding on those opportunities. That is part of the overall workforce approach. We do already do a little bit of, in terms of making better use of skill mix in South Yorkshire with our flexible commissioning practices, which we've already got, which is a focus on access and preventative care. And it just means that the whole workforce is better equipped to actually deal with some of those issues coming into the practice rather than all the reliability being on the dentist. So we are already doing that, and what we are going to be doing is looking at plans to expand that via our commissioning going forward. There's also some legislation change that's due to ensure that dental care professionals can work towards their full scope of practice. So we're just waiting for some change for that. And that's things like hygienists, technicians, and things like being able to sort of prescribe themselves, where currently they're not. And then, as I say, developing the long-term workforce plan. I've listed there the areas that are identified in the recovery plan in terms of what the plan is to actually expand on some of those skills within the dental workforce. The last point in terms of making it easy to recruit more overseas dentists. In South Yorkshire, well actually across Yorkshire and Humber, we are actually looking at some plans in development to do this already, and it's something we'd already started working on and getting through our local programmes. So that it will be something that we are pursuing going forward in 24-25. And in South Yorkshire ICB, we've got a collective now come together between the ICB, people at the Teaching Hospital in Sheffield, with Workforce Training and Education Directorate within NHS England, and we're pulling that together at the minute, and we've got meetings that are now scheduled to actually create our own South Yorkshire workforce plan. Next slide, please. Slide on there regarding dental funding. So our existing dental funding in the budget 23-24 is £112.7 million per year, which sounds an awful lot. South Yorkshire's non-recurrent spending for the current year that we're just coming to the end of, we spent an additional £4.3 million on urgent access sessions in primary care. And going forward into 24-25 with some huge caveats, because our finance colleagues will tell us off if we don't say that, but because these figures are subject to change, we are looking at around a £12.2 million plan to work on investment. That is non-recurrent, that is based on underspends that we actually get from our current contracting. Obviously, the more that we are doing to increase access, that amount will actually go down, and some of the stuff that's been I've explained regarding the new patient premiums. Anything that we're doing to increase access reduces the underspend, therefore reduces the clawback in contracts, which is really positive that we're getting more people access into dentistry, but then it reduces the pot we actually have to do anything differently and looking at other developments. The positive thing there is that the ring fence on the NHS dental budget is there for 24-25, and that was part of the recovery plan. The impact regarding the plan, I mentioned earlier that some of the money that is funding some of these new initiatives for the recovery plan is already within our existing contracts. So it's not all new money, and we don't know on all the different aspects what that new money will really be. Next slide, please.
Shall I just let you catch a breath?
Yeah.
I think members who have been involved in dentistry before will recognise it's very, very complex in terms of the way that the money flows, the contracts worked, the incentives, etc. But there is an important point that Debbie's just made, and it's emphasised again on that slide. That as a NHS South Yorkshire, what we've committed to do is ensure that every penny that is associated for dental goes into dental. And that hasn't been the case across the country, and it hasn't been the case actually within South Yorkshire in the past. Whereas underspends in dentistry have been used to help out with other areas of overspend within the NHS. What we've committed to as a board is that we'll make sure that every part of that underspend is used to do something differently, such as the urgent access sessions, etc., that Debbie describes, to make sure that we keep dental money within dental.
So the Dental Services Board paper, which went to the board on the 6th of March, is fundamentally what the paper is based on that I shared for this meeting. So the purpose of that paper was really to provide the board and provide yourself with the work that's ongoing. So looking at what the current challenges have been, what the current position is and what the developments are. And we went to the board to seek the 3 key principles that are there. 1, commit the utilise of the budget, which we got support from. A commitment to take a level of risk, using more innovative ways for commissioning of services. The dental contract is very specific, it's very limited, it's not ideal, and it is subject to change. Obviously the national team are producing some contract reforms. We had the first stage of that last year, and the next stage is still in discussion. We're still waiting for the next stage, but it is deemed as across the workforce about being unfit for purpose, but it is what we've got. But we want to be able to work more flexibly where we can and within the guidance and parameters that we can do that. But the ICB are willing to take a level of risk on that. And supporting also the priorities that we've identified from the budget and outlining of the principles of the investment plan for next year. Next slide, please. So the challenges, in a bit of a nutshell really, access inequalities. We all know there's a major access issue for dentistry. There's inequalities. We've got practices where they have actually been for a number of years, and they are historical. Some areas, some of our practices have got significant waiting lists for NHS patients. Some of them I speak to, they've got up to 3 to 5 years waiting list just for somebody to be able to see somebody on a routine basis Others are much shorter. It's very varied. The waiting lists are controlled by and responsible by the practices. The workforce is again, it's an issue. Obviously, the reform and the recovery plan talks about looking at ways of increasing workforce. We're also conscious about the workforce on a local footprint, and where we've got practices that are handing contracts back because they just can't continue anymore. Fortunately, in South Yorkshire, we've had very few of those. Other parts of Yorkshire, we've had many more. And also dentists themselves, even within a practice, choosing to do more private work than NHS work. So it is an ongoing challenge that we have those discussions with practices for, but we also need to listen to what the issues are that they're facing. The dental contract, it has its limitations. It's UDA based, but we are using flexible opportunities where we can. Units dental activity, that, as I said, is the tariff. That is how we actually pay our practices on that in the main. We have moved to some sessional stuff, which is based on our flexibilities to do that. And there's a variance across South Yorkshire on what the UDA rate is. And again, that goes back in history, and that's an historical footprint for that. Where we do commission anything new, or we are working with practices to take on any additional activity where we may have had that handed back by practice A and we want to give it to practice B, we do work on the Yorkshire and Humber tariff, which has just been revised, which is quite favourable. I think it's on one of my first slides, and it's £34.30 on a UDA, where you could also see that our lowest practices are paid on £28 a UDA. Contracts and UDA handbacks, as I say, we don't have that many in South Yorkshire. We have had some, but what we have had done when we've had those happen, we've been able to distribute what we've had handed back across existing providers who are performing and performing well, to try and keep that activity within the area it's coming back from, to keep that continuation of patient care for NHS dentistry. Current position, the digital platform, we refer to using what used to be called, it's nhs.net. It identifies where the practices are for dentistry, sort of find a dentist, people would have termed it by. That is still there. That is the existing platform. That's the only digital platform we had for dentistry, and it's on the NHS site. And it does show on there practices that are accepting new patients. Some of those practices may just say that they're accepting adults or accepting children. Children-only contracts in South Yorkshire are historical, and we don't have many of those, and it's not something we generally go out to actually commission for just for children, because we'd rather see the whole patient, the whole family. What it doesn't say is that if you did ring a practice that's advertising as seeing NHS patients, that they've got a waiting list. That is no fault of the practices. They can't put that information on the site. It's very limited to what they can do. We have fed that back through nationally, and I myself have actually asked if I can be part of some ongoing discussions that they're having to change the site slightly on what they can do and what they can't do with that. Patients may also be on more than one list. So we're looking at waiting lists. So we do know that patients, I mean, personally, if I didn't have an NHS dentist, I'd bring in every dentist in my town just to be put on a list. But what you probably wouldn't do is ring back the other 9 when someone has offered you an appointment. So we know there's some issues regarding waiting lists and how validated they are. The latest figures for access are up to 30th of June, and I think that might be on my next slide, for South Yorkshire amongst adults and children, show an improving picture across all our 4 places in South Yorkshire. I'll show you the table in a second. And that there's significantly better access in South Yorkshire than England overall. That's not to be complacent at all, but it just shows that we are in a better position than some of our other areas in England. And also children in South Yorkshire do experience higher levels of tooth decay, both regionally and nationally, and we've got some work we can talk about shortly on that. So I think you've already seen the table there. You can see the figures. So looking at the 30th of June figures, so for example, in Doncaster, 63.4% of adults were seen and 6.5% of children, compared to back in 2019. We weren't, so pre-pandemic levels, we were slightly higher than that. But over the last couple of years, we have got that improving picture because COVID did have a big impact in terms of dentistry.
Again, just to give you a second, recognise this is not where we want to be. I've been in trouble before, particularly from one of the councillors in this room, about saying that just because you're better than the Yorkshire or the England average doesn't make you good. And I don't absolutely acknowledge that's not where we want to be. We are making improvements. I think it's also fair to say that even within those councils, there's significant variation across boroughs and wards in terms of access. So we really want to get into the level of where our residents are really struggling for access and address that.
I think we should be due the next set of data as well, so it will be useful to see where the December 23 figures actually put us with this. So developments. So reference flexible commissioning a couple of times. So flexible commissioning is just a way that we have been able to sort of work with some contracts to flex part of what they do. So we work on pretty much a 10% flex of their contracted activity. So we remove 10% off UDAs and allow some flexibility within the practice to make better use of that, make better use of the skill set. And the current scheme we have is currently based on access and also prevention. We've got 61 practices overall across South Yorkshire that are doing that currently, and we've just extended that over for another year. Because we've got a lot of work going on within the team at the minute across Yorkshire and Humber, because we do still work on a Yorkshire and Humber footprint for a lot of things, but we can obviously put some local flex on that as well. But what we're doing with that is making it a more ambitious way of actually working on that contract. Urgent access sessions for patients experiencing poor oral health. These are where we talked about the urgent access sessions. So these are something we've had running since November 22. And just for 23-24 across South Yorkshire, we've commissioned an extra 6,692 sessions, which is nearly 47,000 appointments in this year. And again, we have continued with those into 24-25, and we're hoping to build on those even more. Improving access for experienced homelessness. So we have got 2 pilot sites in our area. So we've got one in Sheffield, one in Doncaster. Both started at the latter end of Q3, and they started off really well, and they are continuing at the minute. And we're starting to get the data through for that to see what impact that's having. At the board, we had a patient story from a patient of the Doncaster pilot site from one of our charitable organisations that works with homeless individuals, and his patient story was, I think, really well received by the board. I've put the link, I believe, in one of the papers that I've shared with you. If not, we can circulate that after. It is now on YouTube, with his consent to do that, and it is a very positive story of a gentleman that was homeless. He's seeking support with the charity. He's got a history of substance misuse, both drugs and alcohol. He didn't like to smile, he's got a very sunken face. He is now, from his first appointment, was chaperoned to the appointment, and his confidence started to build as soon as he started to receive treatment at the service. He's had some teeth extracted, and the plans are that he will actually receive dentures. It'll fill his face. He's got plans to get employment. He started driving lessons. It's really changing his life. And I'm sure there's other stories very similar to that the service is starting to see. And we would hope that the success of these 2 pilots that we can then look to build across the other 2 areas in South Yorkshire. The acute South Yorkshire and Bassett Law Acute Federation Paediatric Innovator Programme for Dental, it's quite a mouthful. That is something that we're working with the Federation on, and this is very much for us focused on children and those children that are going forward for general anaesthetics for extractions. It's still working through with input from all clinical leads across South Yorkshire, and we're currently doing a bit of a survey across all 4 places and building quite a lot of information in terms of what the current state of play is across South Yorkshire, and actually looking to what we can do to move forward on that to make the pathways much simpler and look to improve services for paediatrics. 2-week wait electronic referrals. We've got a launch in Q1, so a launch by June is the plan, where patients that are accessing dentistry now who get suspected of cancer, currently practices are having to email or even write to our local trusts to actually get people referred. The plan is that this will be electronic. Dental practices are not in the same position as GP practices, so they're on different systems altogether, so they can't just straight away do your sort of patient choose and book appointments like a GP can. So we are looking to improve that situation as starting point for the 2-week waits for patients. And that's in conjunction with our Cancer Alliance colleagues in South Yorkshire. Dental practice service reviews, wherever we get a practice that is coming to us that is finding it difficult to meet their contract, and we support them as far as we possibly can to try and secure that NHS dentistry. The last thing we want to do is for a provider to hand the contract back to us. So we will always try and work with the providers to keep that contract and look what we can do. Sometimes that has resulted in is increasing their activity, their UDA rate. So if they have been on a particularly low UDA rate, example the £28, and they've been really struggling over the last couple of years, we've been working with them to uplift that UDA rate to be at the Yorkshire and Humber baseline tariff. But actually, while we do that, we also then look at what additionality we can get, working with them to build in some NHS 111 appointments for patients, looking at what hours they're currently opening. Can we do some extended hours with that? But looking ways of supporting them, but also looking at what we can do to improve patient access. Next slide, please. You've got it up already, thank you. So commissioning intentions going forward, we've got some key principles. We've extended already the first 3 things on that list. So our existing 6-to-1 practices have been continued for next year to help put some sustainability in the system and just allow us to do the work we need to do regarding changing that scheme and widening it. Urgent accesses have been continued on the current levels I've already mentioned, so they're already informed of that, so they can make their planning already to make sure they've got the staff available to meet that additional need. Homeless pilots we've extended as well. We also then utilise the evidence from oral health needs assessment work and locality profiles that we've already got in, which were done by our public health colleagues. We've got the feedback from the South Yorkshire stakeholder event we did back in November, and looking at what priorities came out of that. And also we've started much more engagement with our local dental committees, and we've met with the chairs of those, and we meet with those on a regular basis. And our local dental network, which is a group that brings together representatives from all parts of our dental pathways, whether it's the trusts, whether it's our high street dentists. We have LDC chairs on that, we've got Health Watch on there, we have our local authority colleagues able to feed in there. So it's quite a mixed membership on that group. So it builds together all the different elements that we feel we need to have those conversations with. Next slide, please. So our key priorities, and this is where our priorities are, and this is where the investment plan going forward is being built from at the minute. So improving access for patients has got to be our number one. So that includes those urgent access sessions I've already referred to, but it's also going to include the ability for our existing practices to overperform, to actually go above their current contracts up to 110%, where that is possible for the practice. Appreciating that not all practices will be in a position to do that, but we want to put that offer out there, and that's something we'll be starting to gather back from practices who is going to be in a position to do that. So that's just one example of what we'll be doing for that. Workforce initiatives, I mentioned earlier on in the slide set, we're looking at things like overseas options to try and increase the workforce out there. Looking at the wider skill set within the practice. So the flexible commissioning approach that we're doing, we'll be looking at that, looking at how we can actually utilise the workforce in those practices much better. Children and young people, flexible commissioning also captures that because it's got a big focus on prevention, but also the federation programme we're doing, which includes those children that are requiring a general anaesthetic to have teeth extracted, which is very high in our area. Orthodontics doesn't get talked about a great deal when we do these events, but orthodontics, we have got big waiting lists. We have got children waiting there on several years to actually receive orthodontic treatment. And this is those children that don't just have a slightly crooked teeth, that these are they have to go through a certain level of assessment anyway by the practice who's referring them to orthodontics, who have to meet a certain level of complexity to go through. So that is something that we are, I'd like to look at to find out actually who can actually do more activity. Again, they are currently restricted by what contract levels they've got, but we can look something to do to address the waiting list. Domiciliary and housebound patients. We have some coverage across South Yorkshire. It is inconsistent. We've got better coverage in some areas than in other areas. And we've got different levels of coverage. So in one of our areas, we've got a very good service which is held up as being a really sort of gold standard service. It does both preventative work as well as reactive work within a number of care homes, where in other areas we've got practices that can just react to somebody who needs an urgent need. We're not going to be able to solve this overnight. There's some bigger pieces of work going on across my colleagues, which we feed into across Yorkshire and Humber. But it is something we need to look at. But certainly for next year, I want to sort of look to see whether or not we have got at least some more capacity out there to provide more coverage while this other work goes on. Digital, I mentioned regarding the 2-week waits. We also have some other areas of our dental referrals that are not currently on any electronic system. It's literally email referrals. So things like minor oral surgery or oral surgery. We want to, as part of a wider procurement piece of work that we're doing, include all different levels of our work streams, so not just currently the 2-week waits, and we do use orthodontics already on a digital platform, but we want to make sure that we've actually got other elements we can put into a digital way. Ultimately, that makes it better, a quicker referral route, but also makes it more consistent, and we can include some levels of triage into that to make sure only those patients that require referral are actually referred. Community dental services, so they're services whereby it is by referral only. These are people that usually have got more complex needs, either health or mental health needs, and the CDS service actually receives referrals through from a referrer. A review went on for that service and it was concluded, and we're just in the process of currently working with our existing providers regarding sort of improvement areas and things for that. But the longer term, we need to do some procurement for the longer term, because our existing contracts come to an end in 12 months' time. So there's some other work going on within the team regarding procurement and going forward. However, I'm building in an element of a funding line because we may need to put some more money into our CDS services. Again, they've got really high waiting lists as well. That's it from me. Thank you.
Well done. There's a lot in there. Chair, we could either pause for questions on this, but I do also want to give Dr. Robertson an opportunity to just describe some of the consultation work and wider public health approach to oral care. So I'm guided by you on which way.
Yeah, I think we'll hear from Sarah as well, if that's all right, and then we won't waste our time with any questions that you might answer as you go on.
Thank you very much. So I just thought I'd just start really with a sort of a snapshot of where we are with oral health in South Yorkshire. I'm not going to go into lots of detail with lots of data, but I'm just going to talk to you about what we know about 5-year-old school children. We have a survey as part of a national dental epidemiology programme every couple of years that looks at the state of the teeth of 5-year-olds, and all the local authorities in South Yorkshire take part in this survey. What we do know is that in the latest survey in 2022, across all the South Yorkshire local authorities, there were actually marked reductions in tooth decay experience since the previous survey, which was encouraging news and reflects the ongoing oral health improvement work programmes across South Yorkshire. However, I have a caveat to that. The figures for South Yorkshire for all the local authority areas was still consistently higher than Yorkshire and the Humber as a whole and England. So I'll just give you a bit of a snapshot really of where we are in, say, Doncaster. So in Doncaster, we're still seeing that there are around a third of 5-year-olds with experience of tooth decay, with each of those children having an average of 4 teeth affected. And furthermore, 30% of the children had active untreated decay, 3% had advanced decay and were likely to be experiencing severe pain and infection. We know that many of these children will have experienced sleepless nights, difficulties eating, difficulties with learning and attention, and time off school for the children and time off work for the parents and carers. So, though things are improving, we mustn't be complacent. There's still more work to be done. We also know that amongst the 5-year-olds, there are pockets of the community where we see the highest levels of tooth decay. So those are found typically where there is deprivation, and also where the community has higher numbers of people from non-white ethnic backgrounds. We also know there's poor oral health amongst looked after children, those with poor mental or physical health or learning difficulties, Gypsy, Roma and traveller communities, asylum seekers and refugees. So there's still work to be done. We also know that in South Yorkshire in particular, we see the highest level of hospital tooth extractions in the country, and that's been consistent over a number of years. But we do also know that tooth decay is preventable, and there are three main interventions really. One is to reduce sugary foods and drinks, so not just the amount of sugar that's being consumed, but the frequency as well. The other is to increase exposure to fluoride, and the third thing is to visit the dentist, so that there could be early prevention. We've already talked about access to dentistry, so I'm not going to go any further along that route, other than to say children should be able to have fluoride varnish applications at their dental practice as a preventive element to prevent tooth decay. So it's really important that children start to see a dentist at as early age as possible. In terms of increasing exposure to fluoride, so again, I've said there's three main ways of doing that. So fluoride varnish application at the dentist, using a fluoride toothpaste regularly, which is something that everybody does at home or should be encouraged to do. And the third thing is water fluoridation, and that's, I think, what Anthony wanted me to focus on a little bit today. So you may be aware that there have been discussions over a number of years around the introduction of a water fluoridation scheme in South Yorkshire, and there have been feasibility studies looking into this. We know that it would have a huge benefit for the people of South Yorkshire. So just a few kind of headlines, I think, about water fluoridation that would be useful for you to know is that the overall evidence for water fluoridation describes a significant reduction in both the number of 5-year-olds experiencing tooth decay and the number of teeth affected in areas with water fluoridation compared to non-fluoridated areas. The evidence also shows that children and young people in areas with a water fluoridation scheme in place are less likely to be admitted to hospital to have teeth removed due to tooth decay than in areas without a scheme. So if all children in the most deprived 20% of areas with suboptimal fluoride levels instead received water with adjusted levels of fluoride, then approximately 56% of extractions in these areas could be prevented. That's huge. And for South Yorkshire, where we have massive deprivation, you can imagine what the impact could be if we had water fluoridation in South Yorkshire. But it's not just children that it benefits. We also know that adults living in fluoridated areas may retain more teeth when compared to adults living in non-fluoridated areas and experience less decay. And there is notable inequality in the prevalence of tooth decay between affluent and more deprived communities, as I've previously said. So people who live in deprived areas will benefit the greatest from receiving fluoridated water, helping to reduce oral health inequalities. We know it is a really safe, effective measure. It's cost-effective. It's the most cost-effective oral health improvement measure in terms of a return on investment. And it also has the lowest carbon footprint as well of all the oral health improvement interventions that we would do. So I'm comparing that with things like supervised toothbrushing schemes. I'm comparing it with distribution of oral health packs, which happens across South Yorkshire through our health visitors. So things like that. It would have an even bigger impact than those things that are already in place across South Yorkshire. So it's quite timely to be talking about water fluoridation today, because you may be aware that in the North East they already have a water fluoridation scheme. We don't have such a scheme in South Yorkshire at present. And the public consultation has just opened today because the government is consulting on whether to extend the water fluoridation scheme up in the North East to reach an additional 1.6 million people. So it's a little bit patchy at the minute up there. Not everybody has the benefit of water fluoridation, and they're wanting to extend the scheme so that there would be 100% coverage. So you might wonder why we should be interested down here when the consultation is about the North East. So it's the first time that there has been a public consultation for many, many years around introducing new water fluoridation schemes or extending schemes. And everyone is looking to see what will be happening through this consultation. The knock-on effect, if it's positive, could be further rollout to other parts of the country, and South Yorkshire could be one of those areas. So we're all invited to take part in that public consultation. You don't have to live in the North East to take part in it, but we would encourage individuals and organisations to have a look at that online public consultation and actually respond to it.
Thank you. We wanted to get that in, and we'll make sure that the appropriate links are sent around to committee members as well. So thanks for that, Sarah. So, yeah, Chair, any questions on anything that we've presented today?
Thanks ever so much. Just give us one moment. Just, so, I think one of our members needs to leave, so I'm just going to take some advice. Okay. I was just checking because one of our members has just informed me that he needs to leave, and that makes us technically incorrect as a committee. So I'm just checking what actions we're allowed to do in that situation. But we can carry on our discussion and our questions. We may have to just be cautious at the end if we want to propose any recommendations. Okay. Glen, do you want to kick off?
I mean, I'm totally sold on fluoridation, and my understanding is that we're kind of in a process. Is that right? In Doncaster or in South Yorkshire? And I also understand that this is a decision that's made now by the Secretary of State for Health, which doesn't fill me with huge whatever. And so I suppose my question is, we have all the facts, and we know that this benefits the most deprived children as well as adults in our community. We know that for an absolute fact. And what can we do? I mean, I will look at that public consultation, but what can we do in South Yorkshire to move that process along? Is there something that we can say as South Yorkshire to the Health Secretary? You know, I absolutely take on board what Councillor Ennis said about Grimethorpe. We have areas of huge deprivation in Doncaster that, you know, I hold my hand up and say, even though I live very close to them, I wasn't as aware previously as I am now of just how challenged some parts of our community are. And, you know, our figures for Doncaster on health break my heart on occasions. And, you know, and I know that it's nobody's fault. Well, I could rephrase that, but I won't. But I just think that is there nothing we can do as a group of elected members, as a group of, you know, people who work in the NHS to say, why can't this happen and why can't it happen faster if we know, you know, without any doubt that this is this biggest single thing that would make a difference to our deprived areas and the children who live in them, who are currently struggling.
So I think everybody has that opportunity to respond to this public consultation in the North East, and I think it's really important that we use this opportunity, because this, as I say, it's the first time this opportunity has come up for a very long time, and everybody is looking to see how this one goes, what the outcome is, because that will then impact on what happens next. So that's one thing that you can do. The other thing, you know, obviously, and the organisation could lobby if they wanted to, the Secretary of State for Health and Social Care, with your support. The feasibility studies for South Yorkshire have been given to OHID, so they are available for them to use if they do so wish to then progress things further. But as you quite rightly said, in terms of the responsibilities, previously local authorities had quite a lot of responsibilities around water fluoridation, and that has now been taken back by the Secretary of State. So it's a situation where we can encourage, we can lobby, you can say what you feel, and encourage, I think.
Yeah, sorry, Chair. I don't think it's one thing. I think it's constant at every opportunity, hence why we're trying to do it again today, to take every opportunity to promote both the benefits, but use all our resources to lobby accordingly. We are very interested in the work in the North East, and we want to be hot on the heels. So what we're trying to position ourselves in South Yorkshire is us next.
Whoops. Thank you. Where to start? I think the National Plan for Recovery, I'm not full of optimism, I have to say, because we're starting from a very low place, and I don't think it looks like enough, and I can hear frustration sort of listening between the lines of everything that you've said, Debbie, that it just doesn't seem enough. And I've got questions about prioritisation, because I think we're in a place now where, you know, ordinarily if something's gone a bit wrong with an aspect of health services, You might put a bit extra resource into closing an inequalities gap, or, you know, put a bit extra in to try and reach people who aren't accessing care. But this is massive, and there are people all over our communities not accessing care. So yeah, you know, put the resource into where the need is greatest, but we've got risk building and building every day in the rest of the population. So, you know, you might target this cohort here or that cohort there, or look at, you know, particularly deprived areas of a city. But risk is building all the time, because we don't have another case study here. I use myself. So I've been off-rolled by my dentist, and I mentioned this back in August when we talked before, and I went on the NHS website and looked for who's taking on adult patients. And in fact, when I discovered from my dentist that I'd been taken off their list, and bearing in mind that a list is a bit of a fictional thing anyway, isn't it? Because no one's a dentist isn't obligated to treat anybody, so the list is a fiction anyway. But having been taken off my dentist's list, I said, "Can I go back on the list straight away, please?" And they said, "Yeah, 2,000 patients waiting ahead of you." I went straight on the website, looked for where I was taking on patients. I found a conveniently located surgery that wouldn't mean a lot of travel, and for a lot of patients they are doing a lot of travel to access a dentist. And they, you know, as you've said, all it says on the website is, yes, we're taking patients. You have that moment of hope, you phone up and they said, yes, we'll take you on the list, but you've got a 4-year wait for an appointment. And I don't think that's unique by any stretch, and other people trying to access the same dentist have had the same message. So that, you know, it's indicative, isn't it, of the scale of the problem. So yes, obviously you have to put resources in where need is greatest. But for me, if I use myself as a case study, where am I going to go now? Now I'm relatively healthy, but I haven't seen a dentist since November 2019. So I think I'm in a risky category now. The feel in my mouth tells me I don't have the perfect dental health, you know. So where am I going to go? I can afford to go private, but why should I? And, you know, I'm one of surely millions of people nationwide in my position. Am I at risk of mouth cancer? I haven't been screened since 2019. I might have mouth cancer. Where do I go to find out? Who's, you know, are we screening for mouth cancer now? Because that was a service, if you like. An early detection and intervention in cancer has been a priority of the NHS for many years. And it's right there in the long-term plan as a priority. But it's like the NHS has dropped that screening process because it was effectively commissioned through dentistry, screening for mouth cancer and throat cancer. So where's that being picked up elsewhere? So these are really big questions, and I know you haven't got the answers because you haven't got the resources to put into producing an answer. But I think it's really important to be fully honest about where we're at. And I think a report that's been picked up by the BBC and our local press here in Sheffield that has the headline, "Access to Dentistry is improving in South Yorkshire," is, you know, I don't know why they've put that headline. Yeah, there's a tiny improvement over the last 2 years, but the bar is really low. And 50% of people not accessing care is not a good news story. So, you know, that honesty, I think, needs to be there as well. And as you've suggested, Debbie, you know, when someone goes on the NHS website, they need to see with the waiting list, they need to see, you know, you're going to be waiting 4 years. I mean, it's just about transparency. It doesn't help the situation. It's just about honesty, isn't it? I don't know what other people can do, what we could maybe do to add a voice to yours in asking for that situation to be put right on the NHS website. You say you've written to, I forget who you said you've written to, but I don't know if more people making the same call would be effective. Maybe that's something we could look at doing as a committee. But you know, I just think we need to be really honest about where we're at. The question I've actually got is, you know, what about people in quite an ordinary situation who aren't accessing care? You know, if you're not in a high priority area or a patient cohort, what about those people?
Why don't I try and address the first point, and then Debbie can come in the specific. So I think we are trying to be as transparent as possible. That's why I stopped in the presentation to say it's not good enough. You know, we want what we want to improve, and then and we need to be realistic about it. We need to publish the data. We need to be transparent, and all is the data can certainly improve. At the same time, Chair, I think it is important to try and create a healthy optimism about what can be done. And the reason I say that is that Debbie's described and I described earlier, there are recruitment and retention issues within the work, and it becomes a self-perpetuating issue of do our professionals want to come and work within the NHS to come in now? I fundamentally believe that they do, but we've got to create an environment that encourages them to come into the NHS and indeed stay in the NHS. So I take every point that you've made, Chair. What we're trying to do, though, is to create some sense of optimism through the schemes that Debbie's described, through some of the incentives that we've got for our profession and our residents to make that improvement. And even small things can create that sense of optimism. That's why Debbie described some of the homeless schemes, etc. So we are limited in what we can do. There is a position that we absolutely need to improve. It will take significant length of time to get to where we want to be, but we do need to create some sense of optimism about the schemes that we've got in place. Sorry, Debbie, you wanted to talk about it.
I was just going to say, in terms of your in terms of changing the digital platform, that is the national platform, they have already come back to me and confirmed they are looking at changes this coming year. I haven't managed to get a definite time plan off them of what's the end date for this, but I have asked to be part of that working group to actually look at how we can change that, because I do feel that the digital platform raises patient expectations. That is the only place we can direct patients to identify those practices that are in those areas, and actually therefore that will show them who is taking NHS patients. And that is something we have to do now. It is part of the dentist practices contract. They have to keep that element of that platform up to date. But by saying they are accepting NHS patients, like you've experienced yourself, is when you actually then ring that practice, they are accepting them, but they'll add them to a list, and it, you know, that is the reality of what many practices are doing, and that is partly compounded by how their contract is and what the national indicators are that we do with that. I am quite keen that we can try and utilise that platform to be a bit more of a reality check, so we can actually indicate on there for patients where they are going to know that that practice does take NHS patients. However, you know, there is a waiting list. Every other part of the NHS has a waiting list, and why should, you know, dental practices are no different, but it's not publicised anywhere. And I think that would be at least a first case, so perhaps people can actually see what that level of a list is, or at least have some element of being able to sort of keep that record on a flowing matter. There isn't, you know, I think like I said, there isn't any answers for some of the points you've raised. We have got shortages, people just wanting routine access. They're the ones that are also struggling. It's not just those that are actually requiring access in deprived communities where we've got high needs. The focus that we have had up to now really has been making sure that people who are in pain, those that are in greatest need, can access. And the urgent access sessions, they have been put in place to supplement the urgent care pathway we have. So when people do ring NHS 111, we do have services commissioned to provide appointments for that across Yorkshire and Humber, and they are just purely urgent care providers who can do that one bit of treatment to help that person who's in pain. And what we've done with the urgent access sessions in primary care is to supplement that, to add some additional resource into that urgent care pathway, because the demand on NHS 11 for dental is huge. The more appointments we can get in the system in primary care reduces the impact on the amount of calls going in. And we can see that in some of the data we're seeing now, that the last 12-18 months are in urgent access session appointments in primary care across a number of practices across South Yorkshire. And it's not all practices in South Yorkshire, but a number of them. The more access we can have in primary care is reduced. We've seen a notable reduction in terms of the number of calls to 111. But we need the appointments in the system. We need those appointments by primary care. And we need the workforce in there to be able to deliver the appointments. One of the ways we are trying to work with the workforce is to commission in a way that's not on a unit dental activity basis. So we're not just commissioning them on an X number of UDAs, we're commissioning them on a sessional basis, because it just provides that more flexibility within the practice, and it provides a better, a more attractive offer for a dental performer to actually want to work in a practice and deliver practices appointments for urgent access. So, and for other schemes as well. So actually the way we can try and be more flexible with our commission things, where we have got the scope to do that, we will do that, because that is a more attractive offer to get dental practices to work. And it is mixed into the complexity of how the contract works. I don't want to get into the detail of that, but we are trying to look at ways we can support the workforce, and actually commissioning in that way, we are receiving positive feedback from dental performers themselves, from practices, and from our LDC colleagues.
I just want to ask about the new patient premium then as well. So if I understand, that's a patient premium paid to practices that are going to see new patients. So what exactly constitutes a new NHS patient? So would I count as a new patient if I went back on the waiting list at the practice that off-rolled me? And there's a whole question behind that, isn't there, that people might start off-rolling themselves and going to a different practice so they can be counted as a new patient. Will people currently on a waiting list at a practice but who haven't been seen yet ever by that practice, would they be counted as new if they're already on a waiting list? And what safeguard is there that people who've already been waiting for an appointment would not be usurped by people signing on new, if you see what I mean? So it's about fairness, I guess, isn't it? And not being able to queue jump, and not that good bit of funding that you're putting in not being abused in any way in any part of the system.
Okay, so yes, so the new patient premium is for patients that have not seen an NHS dentist in the last 2 years. So that's physically seen. So I suspect practices who have got waiting lists will be taking patients off that list who have not seen them. And therefore because those patients that are on the list are waiting for NHS treatment, so some of those will not have been seen for the same length of time as yourself. So it's for anybody that's new into that practice, that's not been seen at that practice for 2 years. There is some monitoring that will be put into place, and there'll be some level of sort of audit check-in at a national level, because all the activity from a dental practice goes into a system. So the forms that you fill in when you go to a practice, that you sign, usually if you're a paying patient or not, they call it an FP17. It goes into a central database, and it's at that level where it can be identified that that patient has not seen anybody for 2 years or not. Whether there'll be any sort of game playing of patients or even practices across the time, obviously they're things that we've raised questions as what if this happens, what if that happens. We are waiting for, we've been involved in a couple of calls nationally with our national colleagues who have been putting things in place with the national database, if you like, to be able to pick and identify things. It's a bit early days at the minute to sort of see that, but we've got there'll be some meetings with us and the national team to look at how those metrics are being looked at and measured, because we have also asked some of those questions about, well, what if they do that and what if they do that? Because the practices fundamentally can only see off their own local records themselves if they've seen that patient within 2 years. If it's a name that they've not even got on their lists, in their systems at all, they will, you know, they will assume that they have not been seen by an NHS dentist in 2 years, go by the patient's conversation with the practice. But when it goes into the sort of big pool, if you like, in the central database national, that's where we can see it. But it's within that practice, so yourself would be able to qualify. You've not seen anybody now for 4 years, so you would be classed as one of those patients that the practice could get a new patient premium for.
Do you want to go in, Glen?
I take on board what you said about overseas recruitment, and obviously there's been some, albeit limited success with this in nursing, in both trusts, first in the acute trust, and now I understand also in Ardash, and I wondered, you know, what kind of steps had been taken to positively encourage dentists from other parts of the world, really.
I think at the minute it's early days for us. We've developed the scheme and the programme and the idea of what we're wanting to do, and put a resource package against that as an incentive to get people to come in. But yeah, so we will be working, one of our clinical leads has been leading on development of that. So we've agreed the programme in principle of what we want to do, the fundamentals of how it's actually going to work in practice. We're not quite there yet, but I think the scheme itself has been endorsed and supported.
Yeah, it has. There's learning to be had from other parts of the system. What I would say, though, is, are the incentives the same for professionals to work in dentistry as what they are in acute and mental health and community trusts? And we've got to ask that question. And you know, that is perhaps at heart of some of the issues that we've got. That has the right emphasis been given to the workforce within such an important area? And what we've recognised in South Yorkshire, and what a learning point as much for me as much as anything, is that good oral health, the impact on somebody's mental health, their ability to work, their ability to be part of the community is massive. So I'm very conscious of using the word commitment, but the emphasis upon oral health and dentistry in South Yorkshire is something that I feel the board are really behind, because it's much wider than the specific issue of being able to be seen by an NHS dentist.
I think the other thing to add as well is that overseas dentists, when they come over into the UK to work as a dentist, they can't just suddenly just come over to UK and work as a dentist. There's a whole package that has to go behind that, in terms of getting a performance number, and making sure that they're, you know, what training they've had, and I think they have to do another examination over here. So it's quite a complex program that sits behind that as well, and making sure then that obviously they can meet all those requirements, and there's some training and support behind them as well. But yeah, so it is still an idea we've supported and a development we've supported, but we've still got some work to go through with our colleagues in terms of making that into reality.
Quick question. The report does talk about underspend in the ring-fenced dental budget, and there's been some noise about that nationally, hasn't there, about where that underspend has been allowed to go, but it's good to see that that's going to be ring-fenced properly again. But that underspend, so is that due to dentists choosing to work privately and not making themselves available to fulfil like the full capacity of NHS appointments that are in the contract?
You said quick question, but Debbie can explain that better.
So the underspend is basically a clawback we've had from our practices' contracts. So it's where a practice hasn't delivered 100% of their contract. We claw the difference back because of how they're paid. We've got many practices that have just been underperforming for a number of years. A lot of that has been down to workforce issues and not being able to fill vacant posts within the practice. I'm not saying some of it won't be down to a performer within a practice deciding to stop doing NHS and purely do private, there will be an element of that. But what that practice as a provider organisation really then needs to do is actually fill that gap to fulfil their NHS contract. So, but it is down to underperformance fundamentally. And that's where we then pull it back. But what we want to try and utilise that funding for is obviously within dentistry itself, but some of the schemes we're actually putting in short term, and obviously with the recovery plan, the new patient premium, that'll start to eat away at that underspend clawback. It'll eat away, so that will reduce. That is the ideal. That will then reduce. We want to make sure all that money is actually spent on people being able to access NHS dentistry.
The principle of keeping dental money in dental is what the board has signed up to. There'll be variation, Chair, on why practices don't meet their contract levels. We're trying to get an accurate reflection of are those contract levels right in the first instance. But it can, and undoubtedly, an individual's decision to where they work privately or NHS will have an impact on some of our practices. But it can be as simple as sickness across a profession. So across a practice, some of our practices are quite limited in terms of the number of people who work there, and any kind of sickness can really impact upon the ability to meet those contractual numbers. It just shows the need to have a much more robust and sustainable workforce, because in certain parts of South Yorkshire it is quite fragile.
I mean, I think where there has been choice, you know, from dentists to work privately, I mean, in a way, you know, who can blame them if the NHS work is not being remunerated fairly? I mean, who's to say what a fair hourly rate is, kind of thing. But, you know, I think where dentists have chosen to work privately, when, you know, the NHS contract isn't being fulfilled through the practice, you can only kind of appeal to them really to think about, you know, the role the players. I mean, dentistry as a whole, if you look at it as like a sort of anchor institution in the community, you know, there's a kind of collective responsibility there, and one person choosing not to work within the NHS contract has a knock-on effect on others, and it has a knock-on effect on patients. And I guess you can only appeal to consciences, you know, to step up and do that and think about the morality of that choice. But I mean, you know, I'm happy to make that appeal today, but I'm not asking you to do that. But you know, it's part of the whole picture, isn't it? Is choice. Have you any more questions, Glynis? We're not out of time, but I don't want us to go on forever. So I guess, you know, I just want to comment that I think, you know, the government's package is, it sounds like a lot of money, doesn't it? But, you know, the Dental Association has reported it thinks there's about 12 million people have unmet dentistry needs in England. And when you look at the numbers, that's like the plan says it's going to provide 2.5 million more appointments, or UDAs, a further 2.5 million units of dental activity, which, you know, it doesn't quite equate to when someone's having a course of treatment. That could be more than one of those, can't it? But if they're providing 2.5 million extra UDAs and you've got 12 million people with unmet need, it's like, do the maths. And I don't know how much of that we're going to see in South Yorkshire, but it's nowhere near 2.5 million extra units for us here in South Yorkshire, is it? And, you know, you kind of think, well, is it going to make that much? Is it going to have that much impact, really? So we can only hope for bigger change, I guess. Any last comments, Glynis? Thank you very, very much for coming. I think because we're only two of us now here, we won't make any decisions about when we'd like to hear from you again in the future, but I imagine we would, at a suitable point in the future, ask you to come back and report on progress and what impact that the shorter term measures that you're putting in, the non-recurrent measures, what impact those have had and what future there is beyond that as well. So, and hopefully we do continue to see an improvement in access, speaking for myself and 1.4 other million people. So thank you ever so much for your time today. Really appreciate it. Thank you. We were asked to note the content of the report and confirm it is assured on the steps, confirm that the committee is assured on the steps being taken to improve access to dental services. I don't know if the two of us can do that, but in principle, I think we can nod on that and make sure that we consult with the rest of the committee next time we meet informally.
Yeah. I mean, next time the committee meets, you can talk about when you want to add it next to the work programme.
Yeah. So I think if Councillor Ennis and Smith and I report back to the rest of the committee next time we have a briefing and see when we'd like to take another report in the future. Is that all right? Thank you very much. Safe journey. We've just got our work programme to agree, but again, we're not court, so we can take an indicative view on that, and if members have anything they'd like to add to the work programme, we can take that, I think, can't we?
Yeah.
Just to note.
It's a request, so yeah.
Yep, Jane.
So just on behalf then of Councillor Ennis, I appreciate he's left and you can't make a decision, but we've still got some quite serious concerns in Barnsley around the new oncology model. And given that we were told in December that we'd get an update in 6 months' time, I wondered if we could bring that forward to the next meeting instead of leaving it until September. So if that's something we could ask the committee about as well, much appreciated.
Yeah, I can certainly pass that on to my colleagues in policy.
So I'm just making a note for myself. So you want that brought forward at the earliest possible?
To the next meeting. We were scheduled to have it in September, but when this came in December, they said a 6-month update would be available. So yeah, I think it's June, the next one.
Katy's nodding.
Okay, thank you. That noted. Anything else? So otherwise, I think we just note the rest of the work programme and look forward to a new municipal year where we can get started again. And I think that brings us to the end of our business. Oh, the date of the next meeting to be confirmed in the new municipal year, June, we think. So thanks very much for attendance today and your input, and see you next time.